last presentation in this session is by Associate Professor Nicole Lee. Nicole Lee is Associate Professor at NCETA and also from Lee Gen. And she's going to be talking much more specifically about treatment options. Thanks, Nicole.
All right, lucky last. Yeah. And technologically incompetent.
Press the right button.
Oh, there we go. All right. There's a lot of hype, I'm going to say, and misinformation around that is, as Nadine said, I think scaring a lot of people off treatment, particularly those at not the pointy end of the pyramid. And what I want to talk about this afternoon is just what we do know really works and what we know about methamphetamine and how that applies to treatment. So we've heard all these things throughout the day. There's not been any increase in the number of people using methamphetamine, probably in the last 15 years or so. But what we have seen is an increase in those people using crystal meth, an increase in the purity of both speed and ice, a smaller price difference between the two, so it's much more economical to buy ice than it is to buy speed, and increase in weekly and daily users, and a whole range of data is showing us that. So what that means is not an epidemic, but an increase in harms, and I think also an increase in the visibility of people. There was a whole group of people who were using happily, who we didn't even notice, using on weekends or whatever, but now they're switching to more potent forms, they're switching to more dangerous ways of using, and so we're seeing concomitant harms associated with that. But we do need to remember that 70% of people, as others have said, use less than once a month. 30% of users use once a month or more, and about half of those use weekly or more. So we're talking at the pointy end, relatively small numbers of people. And what tends to happen is that there's a big group of people who can use for quite a long time without getting into trouble at all. But once you're in trouble, it's really hard to get out of trouble with it. And we don't know who it is that's going to flip over into the regular or dependent use end. But it does mean that we need a different approach for these two groups, really. So the occasional users tend to be not dependent, they're using occasionally, they're probably swallowing or snorting, although there has been an increase in smoking and injecting among that group. They tend to be working a little bit younger. They may be having mild mental health problems, so sleep issues, a bit of anxiety, feeling jittery, a bit of depression. And at the other end, we're seeing dependence or a lot of other problems not associated with the dependence. Tend to be more smoking and injecting, some more severe mental health problems, so paranoia, some psychotic symptoms, and as Amanda was talking about, some fairly serious sleep and nutritional issues that we need to address as well. So you can see that responding to these two ends of the spectrum needs a different approach. And I'm not going to talk about the occasional users. I think Nadine's talk was covered off the harm reduction and secondary prevention measures really well. But I will talk about the tertiary interventions, including treating dependence and risky use. This is a brain. The red bit's the front. You can tell I'm not a neuropsychologist, right? And I wanted to just recap on some of and extend some of the stuff that Rob was talking about, Rob Hester, because that has quite big implications for how we apply our treatments. So Rob was talking about the dopamine pathways. What happens, this is the Nicole Lee non-technical version of how the brain works on meth. There's a bunch of dopamine pathways. Most of them go through the frontal lobe, and it helps the frontal lobe function. And the others go through the limbic system, that's the emotional centre of the brain, and that helps that area function. What happens with meth use is it releases huge amounts of dopamine, and over time, that constant releasing of dopamine basically wears out that system. So that system now cannot produce its own dopamine, or it only produces a very small amount. So you can see that if the frontal lobe and the emotional centres need dopamine to function properly, if you don't have dopamine, they're not going to function very well. They also need to talk to each other. So an emotion might, something might happen, you get an emotion thrown up, and the frontal lobe analyses that and says, do I need to react to it? No, I don't need to get angry, calm down. But when those two systems aren't working together, then that's when we get a lot of emotional dysregulation. I hope that made sense. So what it means is that we have emotional regulation problems, problems with decision-making, planning, all the things, flexible thinking, all the things that the frontal lobe governs, and also impulse control, mood, energy and memory, some of the things that the other parts of the brain function covers. So you can start to see how those cognitive deficits might translate into treatment. Might have trouble getting to appointments. Has anyone ever had that experience? Yeah. Trouble completing tasks. And we know that, as we've heard, CBT and motivational interviewing are best practice for this group and well researched, but they do require a lot of work in the session, and they require a lot of work in between sessions as well. So it might be more difficult to get people to complete tasks, or if they're in rehab, for example, have to go to group, have to organise themselves, that can be quite difficult too. They'll have trouble taking on new information because their attention and their memory is impaired. They might have difficulty thinking about the consequences of actions, so that we get a lot of impulsivity and unexpected kind of behaviours. They might have trouble stopping inappropriate behaviour, switching from one topic to another, so they might get on a topic and just keep going on it without being able to be flexible. And you might expect some unexpected outbursts because of the emotional dysregulation and impulsivity problems. So you can see how this cognitive deficits in the brain translate to problems in the treatment setting, right? Do these sound like kind of familiar issues to do with treatment application? Yeah. The other problem, as Nadine pointed out, this is the same graph really from our study. It's not high science, the study. We just asked people to think back and remember when they had these particular milestones in their using career. So the data is probably a bit noisy, but I think it's consistent with clinical experience as well, which is gives you more confidence. But you can see that between first regular use and first problem use, it's a very short period of time. So once people start using weekly or even monthly or more often, then we start to see quite significant problems emerge quite quickly. And then there is a very short time, virtually no time, between first problem use and first mental health problems. But you can see that the mental health problems seem to come slightly after the drug use. So that does suggest that meth use either increases the propensity or causes mental health problems which is good for us because that means if we treat the mental health if we treat the drug and alcohol problem, we treat the meth problem, then much of the mental health problem will resolve itself, and then we can do what we need to do after that if it's not resolved. But as Nadine pointed out, there's a long time lag, 5 years between first recognising that you've got a problem and coming into treatment. So by the time we see people in treatment and the tertiary treatment services, they're quite severe because they've been carrying these problems around for 5 years, just getting worse and worse. So let's just have a look at what works in treatment. This is from Rebecca McKeaton's study and some other bits and pieces that I've cobbled together. But we do know that relapse prevention, which is CBT, and motivational interviewing are effective, and all the effective psychological treatments are based on one or both of those interventions. So we can be quite confident if we're doing relapse prevention and motivational interviewing, which all of our treatment services know how to do, that we will have a good effect. The trick is in applying that to a meth-using population with all of those cognitive impairments going on. The other thing that I've taken from the treatment literature is that even very small doses of anything is effective with meth users. They're very reactive to treatment, which is interesting. Sustaining that is the biggest issue. To get them to abstinence or to reduce their use is relatively straightforward and relatively easy, and it's just using all the same tools that we use for every other drug use issue. We also know that residential rehab is helpful. The long-term benefits are unclear. Rebecca's study showed an 88% relapse rate from rehab after between 1 and 3 years, so it's a pretty high relapse rate. But keeping in mind that people who go to resi rehab tend to be more complex than people in outpatient services. Pharmacotherapy I'll talk a little bit about in a minute. There's a lot of studies, but not very good outcomes from pharmacotherapy so far. And withdrawal has no short or long-term benefits without further treatment. So one of the biggest issues, as others have pointed out, for meth users is this really protracted withdrawal syndrome. So the green bars there are a typical heroin alcohol withdrawal. Day one, the withdrawal symptoms kick in and they slowly dissipate over 5 to 7 days, and then we're all done and dusted with the withdrawal. But for meth users, you can see that there's an acute withdrawal period that's twice as long as the acute withdrawal period for other drugs, and then a protracted withdrawal period that we think can probably last 12 to 18 months. So, and some of the data that Rob Hester shows those cognitive impairments lasting for that long, and that's probably related to that. So we've got this problem of a long withdrawal period, which, can you imagine, just imagine for a minute how awful and frustrating it would be to feel that level of withdrawal for 18 months before anything changed. We still say for withdrawal, there's not very much research on this, but we still say for withdrawal that outpatient is the preferred option unless there's an indicator for inpatient withdrawal. And that also anecdotally is more satisfactory for the services that provide withdrawal services, the clients that use it, and the meth using clients that use it as well. You saw from Nadine's graph that there is a 2 to 3 day crash period. So there's no point in putting someone straight into detox during that period because all they want to do is sleep. And in a formal detox setting, they can't do that. They've got to get up and start a routine and go to group, and then they get cranky, staff get cranky with them, the other patients get cranky, people are leaving all over the place. It's not a good environment for that first few days. So outpatient, if it's possible, is a good option for this group, using all the same caveats that we use for ambulatory and outpatient detox for other drugs as well, and ensuring that we've got the nutrition and sleep issues covered off during that period. Unfortunately, there's no medicine that's been approved for the treatment of withdrawal. There's a couple that look maybe promising. Modafinil, mirtazapine, dexamphetamine seem to show some benefits for some people. We recently did a large, where this data has come from, a large systematic review for the ANCD, now ANACAD, and looked at all of the treatment studies that have been done around medications, and these were the only 3 that showed any promise for withdrawal. And again, no medicine's really been shown approved for the treatment of dependence either, but some of them do show promise. Now, I think these 5 have shown some benefit for some people, but they'd still be, as Nadine said, off-label prescribing and only used if there's a clear indication. But I think there is a whole load of medications here that people do try using that actually have either shown absolutely no benefit or have shown adverse events. And we have to be very careful not to be prescribing things that are going to make things worse. And then there's a few, from this study, a few that showed not enough evidence. So either there was too few studies, or the studies were very small ends, so we couldn't really say anything about it. But you can see there's lots of different medications tried, and there's many studies associated with those medications, and we're still having trouble pinpointing a pharmacotherapy. So this is a problem for meth users, because when we've done surveys of meth users, they consistently say a medication would help me come into treatment. And there's a bit of, even if there was a kind of placebo effect, I guess, or there's an incentive effect of medication. So it is a bit of a problem. So this means for our psychological treatments that we need to be enthusiastic and confident and be able to say to users, we do have good treatments, come into treatment and we can help you. We do have, these are the 3 main methamphetamine treatments available. 2 of them were developed in Australia. So the first one here, Amanda Baker and I developed probably 2 ice epidemics ago now. And this is a brief cognitive behavioural motivational interviewing intervention, 4 sessions. What we found was that even 2 sessions was better than control. But 4 sessions also reduced depression in those people. So 2 sessions increased abstinence, as did 4 sessions, but 4 sessions also improved mental health outcomes as well. So 4 sessions is not too many for people to engage in. Those long CBT interventions probably don't work that well with meth users. They don't hang around that long. But something even brief has quite a big impact. But if you think back to the long withdrawal period, what we've got is this kind of dilemma. A brief intervention works. Meth users tend only to come into treatment for a very short time, but they've got a really long period of subacute withdrawal or chronic withdrawal that means they're not feeling well for a long period of time. So one of the options is to offer brief interventions like this, 2 or 4 sessions, but then engage in some assertive, supportive follow-up for a longer period of time to ensure that relapse is caught early and that people have the support they need over that 18-month period. Now, the second Australian study compared our brief intervention with ACT, Acceptance and Commitment Therapy, which is all the rage at the moment, and found equivalent outcomes for both. So that's good. We know that we've got two interventions slightly different from each other that are effective for meth users. And the other one is the matrix model, which many of you have heard of. It's very long, complicated, very well suited to the US treatment system, probably less well suited to our outpatient treatment system, but it might be suited to inpatient residential style interventions. It has multiple group contacts a week, plus one-to-one, plus some contingency management, plus urine testing and a whole range of things. So it's quite detailed and complicated. So what we've got is these quite significant brain changes that have resulted in strong cravings because of the lack of dopamine, variable motivation also related to dopamine, impaired ability to manage emotions and thinking processes, a very, very high rate of relapse, potential relapse, long recovery or withdrawal time, and some significant mental health problems. So it all sounds very dire, but the good news is that all of the treatments that have been shown to be effective are just the things that we use every day with other drug users: CBT, relapse prevention, motivational interviewing. So every single practitioner in this room has the skills to deal with meth users, and we just need to communicate that to our clients. Some of the things that we might think about, though, in applying those skills to this particular population is just having a little bit more flexibility around what we do with them. So having 4 sessions once a week for an hour straight after each other, maybe that'll work for some people, but maybe we need to be a little bit more flexible. So we need some flexibility around appointments and systems, knowing that organisational ability is fairly poor. They might not always show up for treatments, or they might show up late. A bit of flexibility with format, so maybe small pieces over a shorter period of time, more frequently. There's no particular evidence. This is just my clinical opinion. But we should play around with how we apply these treatments to see what's more effective. Having things like written materials, because memory's impaired. Remember, memory's impaired, so having a lot of written materials to take away, helping plan for doing homework if you're doing CBT or appointments. So sitting there, I have to do this with my 10-year-old, who I'm sure is frontal lobe impaired. It's normal, apparently. So every Monday he gets a bucket load of homework, way too much homework. And Friday he has to hand it in. And I let him, first term I just let him go and just reminded him, have you done your homework? Yep, sure. Thursday night, hours we were doing homework for him. But now I use some of these strategies and I plan with him on Monday, when are you going to do this piece? When are you going to do this piece? When are you going to do this piece? And then he's all good by Thursday night, half an hour, done, homework done. So these are the kinds of things we can use with meth users too, to help them plan how they're going to implement the things that we've been talking about. Having some memory aids is always helpful, but particularly this group needs assertive follow-up. And there's been some studies in the US showing telephone support post-treatment and follow-up helps people stay abstinent. And it's something that I think we don't do that well in alcohol and drugs. We kind of discharge people and then they're done with us, and then we just wait till they kind of come back into treatment. But having some assertive follow-up for this group, because of the protracted recovery time, is much more important. I just wanted to finish off talking to you about two different ways that groups have tweaked around with the application of treatment in treatment services. So these statistics are from the National Minimum Data Set for Victoria. And some time ago, I helped set up a specialist treatment service at Turning Point, which we called Access Point. And you can see from these data that a different group of people came in and the outcomes were a lot better. So they stayed in treatment for a lot longer, they attended more sessions. And this clinic, although it was called a specialist methamphetamine clinic, it was staffed by people who were just really enthusiastic about treating stimulant use, who communicated to the clients that they knew what they were doing, and really it was all about marketing. We didn't do anything really differently. We still used relapse prevention, motivational interviewing. There was a GP that people had access for primary care services. There was a psychiatrist as well who did some mental health work, and a psychologist and a nurse. But really the treatment was the same as we would offer anyone else, but having a separate service that was marketed particularly for that group, you can see drew a different crowd and also got better engagement. So small, I'm not suggesting that we all have to set up specialist clinics or anything, but you can see small tweaks to services and marketing the fact that, you know, we do know what we're doing and that we have good treatments makes quite a big difference to treatment access. And the other thing, the other little piece I wanted to talk about was Uniting Care Regen's work in withdrawal for meth users. So there's I was involved with the evaluation of that program. This is how I know about it, but there's a report on their website if anyone's interested in having a look at that. It's a step up, step down, stepped care type withdrawal program. They utilised, you know, as I was talking about, the first few days are just the crash period and everybody's irritable and no point in putting people into resi withdrawal at that point. So they utilised their outpatient withdrawal, home-based withdrawal team to get people through that first few days. Then, if that was appropriate, some people just were fine after that and kept going with the home-based withdrawal. But if that was appropriate, then they put them into residential detox. And then the home-based withdrawal team picked them up at the other end and continued on, knowing that we only really have, we're only funded for 5 to 7 days, really. So, you know, they couldn't stay in for very long, but they finished their withdrawal in the community. So using some innovative use of resources had some really good effects with that group. That's really all I have to say. If you have any questions, I'm happy to take them.